Hello, my name is Rudy Nunez. I'm a Pharmacist Candidate, class of 2024. This is my drug information presentation highlighting lithium, also known as Iscalith or Lithobid. This medication also has various other brand names in which it is available. I won't be going too far into the pathophysiology of any illnesses. We're just going to be simply going over drug information and some of the details of the medication. So for a little background about lithium, it is known as an antimanic agent. It was first discovered in 1949 and it gained more popularity after its FDA approval in 1970 for the treatment of acute mania. I was looking further in depth into why it took so long to get FDA approval, and some theories are that because it is a naturally occurring element, there is no real company that holds a patent for this medication, and thus there's no real financial incentive for this medication to be studied. But if you do look further into the literature, are thousands of studies and journal articles written about lithium just because it is interesting in how it is working in the body. It is only prescribed in settings where serum concentration monitoring is available, and this is because it can be toxic. Lithium does anecdotally remain the single most effective psychotropic agent in all of psychiatry and has applications in treatment of bipolar disorder and major depressive disorder. To this day, it's not FDA approved for major depressive disorder, but it does seem to work. As far as its pharmacokinetics, we do like to break it down into ADME processes. Absorption, it has a 90 to 100% bioavailability. Food has no real effect on absorption of the medication, although we will see that food does have interaction. Distribution, it has a volume of distribution of 1.4 liters per kilogram with no protein binding. 1.4 liters means typically that it tends to stay in plasma concentration. Metabolism, it is not metabolized. But elimination, you'll see that it is renally eliminated 89 to 98%, and it can be fecally eliminated by 1% with a half-life of 14 to 24 hours. Now, lithium is known as an antimanic agent, but its antimanic effect and the mechanism of action for which it has an antimanic effect is relatively unknown. Here are some mechanism of actions that can be proposed. Lithium is known to alter cation transport across cell membranes in nerves and muscle cells, and it can also influence reuptake of serotonin and norepinephrine. It may also provide neuroprotective effect by increasing glutamate clearance, inhibiting apoptotic glycogen synthase kinase activity, increasing levels of anti-apoptotic protein BCL2, and enhancing the expression of neurotropic factors. This also includes brain-derived neurotropic factors. So with that said, what does lithium treat? In the next slide, I'm going to go into further depth into what the indications are for using lithium clinically. But if you asked just the general question, what does it treat? It can be used to treat bipolar disorder, mood disorders, suicidal thoughts and ideation, and even some neurodegenerative diseases. But the caveat here is that it is an older drug. It does have a lot of monitoring involved in it. It does have toxic effects, and it could interact with multiple different drugs and lifestyles. And so I did want to put it in this bookmark here and just kind of say that if your provider doesn't think lithium is the right choice for your patient, then we have to take that into further consideration. There are new medications and new agents that are being studied and used and are very successful at treating patients with bipolar disorder. But in this presentation, we're going to discuss just some of the indications for lithium, but it is not for all patients. So lithium is indicated for bipolar disorder, and in this slide I wanted to give a breakdown between the difference in maintenance therapy and the therapy for manic episodes. Here we do have formulations between extended release and immediate release. In maintenance therapy, for adults and children greater than the age of 12 years old, extended release therapy includes 900 to 1800 milligrams per dose in 2 to 3 divided doses. Immediate release, we have to titrate. We initially start with 300 milligrams daily, then we get titrate up to 900 to 1800 milligrams in 3 to 4 divided doses. For bipolar manic episodes, this is again for adults and children greater than the age of 12 years old. We start with extended release formulations, 1800 milligrams per day and 2 to 3 divided doses, or immediate release formulation, 600 milligrams 3 times daily. So with the dosing discussed in the previous slide, now we have to discuss monitoring parameters. Drug levels can be drawn prior to the next dose, or an 8 to 12 hour trough can be done to assess the patient's levels. And then after that, about every 5 days after the dose adjustment. So once the patient is stable, then you can test every 5 days. Acute mania, our desired drug concentration is going to be between 0.8 and 1.2 milliequivalents per liter. In maintenance, the level is a little bit more broad. It could be between 0.6 and 1.2 milliequivalents per liter. Levels should never exceed greater than 2.0 milliequivalents per liter. In terms of toxicity, kidney, thyroid function needs to be assessed. Hydration status and sodium levels are also important to maintain. Periodic EEG and ECG exams should be performed. Renal function, including BUN and serum creatinine clearance at baseline, and then every 2 to 3 months during the first 6 months of treatment, and then you can do that annually afterwards. Serum calcium base level, and then 2 to 6 weeks after initiation, then every 6 to 12 months. And again, we're going to repeat these as clinically indicated. With lithium, warnings and precautions include a black box warning for lithium levels that are required. We also have contraindications for patients with severe debilitation, dehydration, or sodium depletion. We have cardiovascular disease, significant renal impairment, and concomitant use of diuretics, contraindications. And we also want to avoid use in pregnancy and lactation. In terms of adverse events, we often like to break it down between common, less common, and rare but serious. In common, it happens in greater than 10% of the patients. We have cardiac dysrhythmias, tremors, otherwise, or fine tremors in this case, hypothyroidism, leukocytosis, thrombocytopenia, and cerxomias. In less common side effects, we have ataxia, blurred vision, nausea, vomiting, diarrhea, EEG and ECG changes. We also have headaches, muscle weakness, oliguria or polyuria, somnolence, or tinnitus. In the rare but more serious side effects that happen in less than 1% of patients, we have hypotension, nephrotoxicity, seizures, hypercalcemia, and hyperparathyroidism. With lithium having a very low volume of distribution, we do have its levels fluctuate due to other factors, and this table summarizes some of those factors. So things that could increase lithium levels include renal disease, NSAIDs or the use of NSAIDs like Motrin, low sodium, being elderly or of older age, ACE inhibitors or ARB use, furosemide, renal disease, or dehydration. Things that could decrease lithium levels include mania, drinking coffee or caffeine use, high sodium, pregnancy, acetazolamide, mannitol, aminophylline, or theophylline. Some of the counseling points for when initiating a patient on lithium include counseling the patient to swallow extended release tablets whole, do not crush or chew, avoid activities that require mental alertness, at least until the drug effects are realized, report signs and symptoms of toxicity, and this again can include vomiting, diarrhea, nausea, ataxia, drowsiness, muscle weakness, lack of coordination, blurred vision, tinnitus, and large volumes of dilute urine, and maintaining fluid intake and normal salt intake. Again, we're trying to stay at the normal level, and if any of these factors as described in the previous slide start to influence our serum levels, and we have to make an adjustment to the dosing. Some of the clinical pearls: safety and efficacy in patients younger than 12 years old has not been established. Again, so when we discussed the dosing, it was always for adults and children older than 12 years of age. Safety and efficacy has not been established for children at this point. Lithium toxicity is highly related to sodium lithium levels, and it can occur at doses close to therapeutic levels. This is known as having a narrow therapeutic index. Manic phase requires a higher lithium concentration when manic symptoms subside. And again, if the patient is manic, then it could decrease serum concentrations, and so it can also require a higher dose. Do not confuse doses of milliequivalents with milligrams. Patients should be dosed in milligrams. And here I just added that lithium 300 milligrams equals 8 milliequivalents. And on this slide are my resources that I used. Thank you again for your time and attention in this presentation. Again, I encourage you to do your own research and really look into this medication. It's got a very interesting history and therapeutics behind it. Thanks again.